Hello, and welcome to the ASCO Daily News Podcast. I'm Dr. Shaalan Beg, your guest host of the podcast today. I'm the Vice President of Oncology at Science 37 and an adjunct associate professor at UT Southwestern Simmons Comprehensive Cancer Center. My guest today is Dr. Mohamed Salem, a GI oncologist at the Levine Cancer Institute at Atrium Health. We'll be discussing key posters and oral abstracts in GI oncology that will be featured at the 2023 ASCO Annual Meeting. Our full disclosures are available in the transcript of this episode, and disclosures of all guests on the podcast can be found in our transcripts at asco.org/dnpod. Mohamed, thanks for coming on the podcast today.
Thank you, Shaalan.
There's some interesting studies in colorectal cancer that I'd like to get us started with today. Abstract 3547 is a phase 1 dose escalation study of GCC19 CAR-T. This is a novel coupled CAR therapy for patients with metastatic colorectal cancer. What are your thoughts on the study?
Actually, this was a very exciting study to see coming out in GI cancer, especially colorectal cancer. As you know, CAR-T made its way to the treatment of lymphoma and other heme malignancies. In fact, we saw fascinating response and outcome using that technique and that niche in immunotherapy model. The challenge we had that we could not replicate this in solid tumor until very recently. I'm sure you had the same thing in your clinic too. A lot of patients with GI cancer or colorectal cancer come to you and say, okay, why I can't have CAR-T? And the response was, we don't know if it's effective or if it's going to work yet. We here on our center, we had a phase 1 study, I think that was looking also on CAR-T and solid tumor, particularly prostate cancer. So that I think was very exciting to see that technology is making its way to the solid tumor. I was very pleased to see like this CAR-T study coming out from the work of our Chinese colleagues looking into this in the CRC space. Obviously, as you know, in colorectal cancer, we made a significant advancement, but I don't think we made enough advancement yet. And especially for refractory patient, a patient with refractory disease that they underwent multiple line of therapy. And this study actually addressed the need for those patients. So in this study, that was a phase 1 escalation dose. Very much as you looked at about 13 patients who had metastatic CRC, they had at least 2 lines of therapy. So in quote unquote, what we say refractory setting. And unfortunately for those patients, we don't have a lot of treatment option. And they used 2 doses, the first dose and the second dose that was a little bit higher. And the interesting part is that they were able to see very nice responses on this patient population. In the lower dose, I think the response was, the PFS was about like 1.9 months. But when they went up on the dose, actually the PFS was 6.3 months. Which I think in the refractory setting is very meaningful. And also the median overall survival for the first group was 13 months, which in refractory setting, that's something we don't see often. And the higher dose was 18 months, which even better. So there was appeared to be a trend that higher doses is perhaps more effective or have better efficacy than lower dose. But also in terms of side effect, they actually patient relatively were able to tolerate that well, and was no surprising adverse event. So again, yes, that's a 13 patient total, so it's a very small study. But like everything else, the proof of concept sometimes is first step, and it's very important to see that data to suggest that this technology now can be utilized in solid tumor and CRC. Especially now, there is unmet need for those patient population. I'm sure you and I will see a lot of patients in the clinic with good performance status and just looking for the next option. And I'm glad to see that. Hopefully, we can continue to build on that work.
Another key abstract in colorectal cancer is abstract 3513, the CodeBreak-101 study. This is a phase 1b safety efficacy trial of sotorasib plus panitumumab and chemotherapy with FOLFIRI for previously treated KRAS G12C mutated colorectal cancer. And this is a really important study because even though KRAS G12C represents a minority of KRAS mutated colorectal cancer, we know that this treatment can cause meaningful improvement in disease for other cancers like non-small cell lung cancer. And when sotorasib was tested as monotherapy in colorectal cancer, it saw an objective response rate of 9.7% that increased to 30% when added to panitumumab. So on this trial, they took sotorasib plus panitumumab and added it to chemotherapy to see how it's tolerated and what its effectiveness is going to look like. And they enrolled people who had more than one or more lines of prior therapy for metastatic disease. They treated 33 patients. The most common side effect was dermatologic. It's probably related to EGFR-based therapy. And they saw a confirmed overall response rate of 58%. Side effects are those that we look to expect with this specific regimen. I don't see any additional safety concerns here, but this can be a big step forward for KRAS G12C altered colorectal cancer. What do you think?
I totally agree. And again, it was very exciting to see that abstract and that result. I totally believe now, and I'm sure you would agree with me too, that Shaalan, that we're moving from an era of like one size fits all to like a precision oncology and tailored treatment. And the fact now we have a treatment option for patient with KRAS mutation is very exciting, because before we didn't have much that we can do about that mutation. So now it's not just a proof of concept. Now you're hitting that target with the chemotherapy and you're getting 50% response rate. That's something interesting also to see for this patient population. And as you highlight, the safety also and the adverse event was not high, and patients were able to tolerate that, which make it like more doable for us to use it.
Yeah, and one of the challenges in the precision oncology space, which I'm sure you're experiencing in clinic as well, are the real world applications of precision oncology and the drop-offs that happen that are preventing us from universal precision oncology, meaning the drop-offs that we see on eligible patients receiving the appropriate genomic testing, those who have genomic testing receiving the appropriate treatment. And we've seen a couple of fairly high-profile studies that are describing this in non-small cell lung cancer, where the rates are not as encouraging as we would want it to be, which to me as a physician makes me worried that there are people out there who we don't know are carrying these mutations or have these mutations and it hasn't been acted upon. And related to that, there is an abstract at ASCO 23, which is abstract 3602, that looked at the real world rates of FDA approved targeted therapy and immune therapy for people with metastatic colorectal cancer. They used the VA's National Precision Oncology Program data to study the prevalence of these mutations and how many of the folks ended up receiving the treatment that would be appropriate for those mutations. And this is a very exciting study. They looked at 908 metastatic colorectal cancer patients who underwent genomic profiling. 81% were colon and the rest were rectal. They found that 34% of patients harbored NRAS, KRAS, BRAF mutations. 9.6% harbored were TMB high. 7.7% had BRAF V600E, and 5.6% were MSI high, which kind of puts the overall actionable variant prevalence in colon cancer at 47% and for rectal cancer at 44%. And then they went down to see amongst those 424 eligible patients, how many ended up on appropriate therapy. And these were their numbers. For MSI high, 70%. TMB high, 47%. NRAS, KRAS, BRAF, wild type, 38%. BRAF V600E, 17%. So nearly 30% of patients with MSI high colorectal cancer did not receive immune checkpoint inhibitor therapy. And again, other aspects in terms of EGFR use, and I know that there are other challenges that may affect the use of EGFR inhibitors in colorectal cancer, but really begs the point on aspects related to implementation science, on getting the testing and acting on those results. And I'm curious to what you're seeing that's being done on these initiatives nationally.
Totally agree with you, Shaalan. This is a big problem we're facing day in and day out, because we struggle to find treatment option for our patient. And I think if we're missing patient with targetable or actionable mutation and we're not utilizing that, I don't think that's a good situation to be in. And I think that's just a group effort. You have to work with the pathologist, you have to work with your team in the clinic, and as an oncologist treating this patient, we have to pay close attention to those marker and frankly just look for them. I mean, at least the ones that gonna have therapeutic implication. I do also think patient advocacy has a huge role here and huge opportunities that they can contribute. I'm sure you are familiar with pancreatic studies that was published by our colleague Mike Bishfin in Lancet a year or two ago, and I think he named it Know Your Tumor Type. I think that should be the way forward now, not just for pancreatic, for any cancer. Patient should ask their oncologist what my tumor is. Is that MSI high? Is that KRAS G12C? Is that BRAF? Because it will affect the treatment. So I think it's a multi-layer, and all of us should work in a cohesive manner to be able to not ever miss those markers which carry therapeutic potential.
So let's move on to hepatocellular carcinoma. Dr. George Lau and colleagues, they'll be sharing data from the phase 3 HIMALAYA study for hepatocellular carcinoma in the annual meeting. That's abstract 4004. And he looked at outcomes by occurrence of immune-related events for people who received tremelimumab and durvalumab. What are your thoughts on this study?
This was a very interesting abstract to see. For a long time, we didn't have much of treatment option in hepatocellular carcinoma. So over the last 2-3 years now, I think we make nice advancement in the therapeutic landscape. So we have multiple options, including immunotherapy, which is very exciting for all of us to be able to utilize those powerful drugs in that disease. Obviously, in HIMALAYA, we don't have a lot of biomarker like the immunotherapy biomarker like MSI high and PD-L1 and TMB. It is not really play a huge role in HIMALAYA. So as you know, the HIMALAYA study that was phase 3 study examined the STRIDE regimen, which is tremi plus durva in the first line of patient with metastatic or unresectable HIMALAYA against sorafenib. And the outcome was in favor of the STRIDE regimen with improvement in OS response rate and duration of response. And because of that, became one of the standard of care for that disease. But that abstract 4004 actually asking a very interesting question that in our mind, whether immune-related adverse event can predict outcome, meaning like those patients who experience immune-related adverse event will likely to do better compared to those patients who didn't experience immune-related adverse event or not. The idea of adverse event as a biomarker, if you will, for efficacy is not new. I mean, we saw that back in the renal cell carcinoma, TKI, the hypertension. People who had hypertension were more likely to have a better response. In the GI also, there was some data suggesting that rash might be a predictor biomarker in predicting response to anti-GFR. So the same question was applying here. Immune-related adverse event can function as a biomarker for efficacy for immune system. And there are some data out there in other tumors suggest perhaps that may be the case. But I think at least to my knowledge in the HIMALAYA or GI, this was the first study to address that question. So just remind our audience that the HIMALAYA obviously was a phase 3 study, used the STRIDE regimen as a front line for patients with hepatocellular carcinoma, either unresectable or metastatic disease, and they compared the STRIDE, which is durva-tremi, compared to standard of care at that time was sorafenib. The primary endpoint was overall survival, and they had secondary endpoint, duration of response, response rate, and obviously adverse event. The study was positive. It met its primary endpoint, and OS was in favor of the STRIDE regimen compared to sorafenib. But that part of the abstract now is focusing mainly on those patients who had immune therapy, and whether that was a STRIDE regimen or the third arm, that durva alone treatment, and they're looking at those patients who had immune-related adverse event, those who didn't have immune-related adverse event. So basically, 4 group patient, the patient who had a STRIDE regimen, about 139 patients had immune-related adverse event, and about 249 didn't have immune-related adverse event. For the cohort who had durva alone, about 64 patients had immune-related adverse event. Almost 300 patients had no immune-related adverse event. And it was very interesting that at least in the stride arm, those patients who experiencing immune-related adverse event, their outcome was better than those patients who did not have immune-related adverse event. The same trend was seen on the durva alone arm, but I think the number was very small to make a statistical value out of it. But I think at least in the stride arm, there was positive trend toward the outcome of those patients who experience immune-related adverse event. So I think this is, in a way, very interesting because we're always wondering, like we give the same dose, at least in like an immunotherapy, like for everyone. We're always wondering, it is too much, is too little, or just right. It's hard to know for sure, but perhaps in my opinion, and just me like trying to understand why that, in my theory, maybe that's just an indication of like patient receiving enough drug and effective drug that will translate into efficacy. But on the same time, I also wanted to just put a word of caution here because we don't want it to see side effect as a good thing. I think we want to make sure that us as an oncologist treating this patient and patient also don't see like it's good to have a side effect. Side effect associated with, especially those grade 3 or 4, can be associated with significant problem and decreased quality of life. So we definitely should be looking at those side effects and be careful interpreting those data. But I think that is very interesting, and I will look for more work on that.
Let's move on to pancreatic cancer. We heard the results of the NAPOLI-3 clinical trial at GI ASCO, and this year in ASCO 2023, we will hear the results of abstract 4006 by Dr. O'Reilly that are presenting results of the 12 and 18-month survival rates from the study that compared NALIRIFOX, or nanoliposomal irinotecan, 5-ethylocouvorin oxaliplatin, versus nab-paclitaxel gemcitabine for newly diagnosed pancreatic cancer patients. I'm interested to what you think about that study.
Thank you, Shaalan. So this also very exciting abstract to see. And anyone who treat pancreatic cancer patient, they realize that unfortunately, even in 2023, we don't have a lot of treatment option. And yes, I think over the last decade now, we're talking about second line and third line, but yet still we don't have a lot of treatment option. So having more option is always good. But the question now, how you sequence those chemotherapy option? Most of us, obviously, we use FOLFIRINOX in the first line, or nab-paclitaxel, gemcitabine and nab-paclitaxel in the first line. Until very recently, we could not, because we didn't have a head-to-head comparison, we could not tell patient for sure, like if one is better than the other. I think we have some assumption, but was not really proven. It just was a cross-trial comparison. So the fact is that now we have that phase 3 trial looking at liposomal irinotecan, 5-FU, and oxaliplatin, comparing to nab-paclitaxel and gemcitabine. To me, that was actually very exciting because now at least I see like triplet chemotherapy drug compared to doublet chemotherapy drug. And as you mentioned, Shaalan, the first initial read was positive in favor of the triplet regimen compared to the doublet, which I think was an important message to give to our colleagues and all of us that if you can, obviously triplet comes with side effect, but if you can deliver the triplet, that's perhaps a better starting point for the treatment. But the study here, we're trying to get like a more read after more mature or more time lapsing. So the initial read was positive. And I think this is a good also to see that because it just translates that even with a longer follow-up, we're still seeing the same benefit. So the OS rate in 12 months for the triplet was about 45% compared to 39.5% to the doublet. And the 18 months, year and a half, 26% compared to 19%. So definitely you see like improvement in every single endpoint. OS in general was 11.1 months compared to 9.2 months, and PFS also was in favor of the triplet. So I think is a message here just to enforce what we saw a few months ago, in the initial presentation that, in fact, the triplet is associated with better outcome if you can safely and manage the toxicity and guide patients through the process.
Well, thank you very much, Mohamed. This was a lot of fun. Thanks for sharing your valuable insights with us on the ASCO Daily News Podcast.
Thank you for having me, and looking forward for the full presentation and the meeting. And please, if you didn't register for the meeting yet, make sure you attend. It's a wonderful opportunity to learn from an expert in the field and also meet your colleague and make new friends. I also want to take an opportunity to thank the ASCO Daily News Podcast team for taking the time, and also for our colleagues who review those abstracts. This takes a lot of time and effort, and I think they're doing a wonderful job. So thanks to all of them, and see you all at ASCO.
And thank you to our listeners for your time today. You'll find links to the abstracts discussed today in the transcript of this episode. I'll be back to cover late-breaking abstracts and other key advances in GI oncology after the annual meeting. So please join us for more key insights from ASCO23 on the ASCO Daily News Podcast. Finally, if you value the insights that you hear on the podcast, please take a moment to rate, review, and subscribe wherever you get your podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.